Good day to you all. Hi, I'm DJ Rokoma, and we're going to discuss about the classifications and the pathophysiology of dental caries. But first off, what are dental caries? This is widely known as tooth decay or cavities. It is one of the most common and widespread persistent diseases today, and is also one of the most preventable. When you eat certain foods, the bacteria on your teeth breaks them down and produces acids that have the ability to seriously damage the hard tissues of your tooth. The result is the formation of dental caries. There are two types of classifications of dental caries. First, the GV Black caries classification, and the other is according to the severity of caries in the tooth. Dr. G.V. Black developed a system to categorize carious lesions based on the type of tooth affected, anterior or posterior tooth, and the location of the lesions like lingual, buccal, occlusal, and etc. 6 classes of carious lesions according to G.V. Black: Class 1, Class 2, Class 3, Class 4, Class 5, Class 6. Class 1 is cavity and pits or fissures on the occlusal surfaces of molars and premolars, facial and lingual surfaces of molars, lingual surfaces of maxillary incisors. Class 1 corresponds to surfaces of a posterior tooth you can clinically see, just like occlusal, lingual, and buccal surfaces. Therefore, the interproximal surfaces are not classified as Class 1. Class 2 is cavity on proximal surfaces of premolars and molars. Class 2 corresponds to surfaces of a posterior tooth you cannot see clinically. Class 3, cavity on proximal surfaces of incisors and canines that do not involve the incisal angle. Class 3 corresponds to surfaces of an anterior tooth you cannot see clinically. Class 4 is proximal surfaces of incisors or canines that involve incisal angle. Class 4 lesion is larger version of Class 3 that covers the incisal angle. Class 5 is cavity on the cervical third of the facial or lingual surfaces of any tooth. Class 5 lesion is technically at the neck of the tooth. Class 6, cavity on the incisal edges of anterior teeth and the cusp tips of posterior teeth. Class 6 corresponds to the very top surface of a tooth. The other caries classification is according to their severity. The appearance of interproximal caries can be classified as incipient, moderate, advanced, or severe, depending on the amount of enamel and dentine involved in the caries process. The severity may continue to increase if not treated. Incipient is a lesion that extends less than halfway through the enamel. Moderate is a lesion that extends more than halfway through the enamel but does not involve the dentino-enamel junction or DEJ. Advanced lesion is lesion that extends to or through the enamel junction but does not extend more than half the distance to the pulp. Severe is a type of lesion that extends through the enamel, through the dentine, and more than half the distance to the pulp. Now we proceed to the pathophysiology of dental caries. By the word pathophysiology, it is a convergence of pathology with physiology. This is the study of disordered physiological process that cause, result from, or are otherwise associated with disease or injury. Oral disease continues to be a serious public health problem in the Philippines. The prevalence of dental caries on permanent teeth has generally remained above 90% throughout the years. About 92.4% of Filipinos have tooth decay or dental caries, and 78% have gum diseases or periodontal diseases. Although preventable, these diseases almost affect every Filipino at one point or another in his or her lifetime. Aside all that, let's focus on dental caries. This Venn diagram summarizes the complexity of caries development. Many variables can contribute to the caries process. Caries develops when there is a susceptible tooth exposed to pathogenic flora, in other words, bacteria, in the presence of substrate or specifically the surface on which an organism grows. Under these conditions, the bacteria metabolizes substrate to form acid, which decalcifies teeth. As shown in the Venn diagram, caries can occur if oral flora contains acid-producing bacteria, such as Streptococcus mutans. Bacteria growth is determined by the frequency of exposure, the amount and kind of substrate available for metabolism, the state of oral hygiene, and the presence of fluoride. The susceptibility of teeth varies with age, fluoride exposure, morphology, crowding, nutritional status including trace elements, and presence of carbonic acid. The caries process begins on tooth enamel, which is composed mainly of minerals in the form of hydroxyapatite. Primary tooth enamel is thinner than permanent tooth enamel and does not have the benefit of fluoride incorporated within the structure of enamel during development. Normal oral flora, both good and bad, colonizes the mouth soon after birth, well before first tooth erupt. Studies have demonstrated that cariogenic bacteria adhere to the intraoral mucosa prior to any tooth eruption. Cariogenic bacteria are transmitted from the mother, sibling, playmate, or primary caregiver, all of whom harbor this bacteria, to the infant at or before the eruption of the first tooth. The mother or caregiver should be informed and understand that pre-tasting, pre-chewing, and the sharing of utensils should be avoided because bacteria are transmitted through the saliva. The window of infectivity is greatest during the child's first 2 years of life. If colonization is delayed, the risk of caries decreases, therefore improving the mother's or the primary caregiver's oral health and providing oral health education can reduce the risk of caries in the child. Children whose siblings have caries are also at high risk for caries development. Clinical observations suggest that second and third infants tend to be colonized earlier. Fluoride and the frequency of ingestion of fermentable carbohydrates are the two greatest issues in the fight against dental caries. Frequent exposure to small amounts of fluoride each day is the best way to reduce risk for developing tooth decay. Fluoride combines into the tooth structure to make enamel more resistant to acid attack. After ingestion, fluoride passes from the systemic circulation into saliva and is constantly available to repair initial acid attacks. Fluoride decreases the production of acids that cause tooth decay. Fluoride that is concentrated in the dental plaque and saliva inhibits the demineralization of sound enamel and enhances his remineralization. After remineralization, the enamel is more acid resistant and contains more fluoride and less carbonate. Demineralization and remineralization can thus occur at the same time and the same lesion depending on concentration gradients of fluoride, carbonate, magnesium, and the acidity of liquid. To summarize, the bacteria are transmitted from the primary caregiver to the child. Caries is promoted by carbohydrates, which break down to acid. Acids causes demineralization of animal. Frequent snacking promotes acid attack. Foods with complex carbohydrates, such as breads, cereals, pastas, and fruit juices, are major sources of hidden sugars. High sugar content in sodas, fruit juices, sports drinks is a source of substrates. We are all at risk for dental problems. However, it is easily preventable. Aside from brushing and flossing after meals, a regular visit to the dentist prevents dental problems. Do not wait for mouth pains or toothache to see a dentist. Remember, dental issues are connected to your overall health, and that is why you should take good care of your mouth. This is DJ Rakuma. Have a great day, and thank you for listening.